Here. All right. Good evening, everyone. We're going to get started. And before we start, I'd ask if everybody could mute their phones or their computers so that there's no background noise. And a couple reminders. Should any technical difficulties occur, we appreciate your patience and understanding as we work quickly to address them. Remember that private chat is never fully private, so just be aware of what you write in the chat box. At the end of the presentation, we ask that you fill out the evaluation surveys, and that is in the chat box. I did provide a link, and I will provide it again. And we ask that you hold your questions until the end, and you can either type the questions in, or at the end of the presentation, you can ask them. So I would like to introduce our speaker, Dr. Dupre. Dr. Dupre is the medical director of the Capitol Health Sleep Lab and a board-certified neurologist and sleep specialist. After completing his training at the Mayo Clinic in Minnesota, Dr. Dupre has returned to his home and place of birth in Mercer County, New Jersey. So welcome, Dr. Dupre.
Thank you very much. Can you all hear me okay?
Yes.
Yes.
Perfect. Okay. And I just figured out how to pull up the chat box. So exactly as you said, preferably let's keep the questions for the end. We'll definitely allot time for that. If you have a deep burning question that is either going to slip your mind or you must know, must ask, etc., then sure, throw it in the chat box and I'll be perfectly happy to answer. All right. So this is my my son, who's a good bit older than this now. He was this old when I named the talk, and I've since been intending, and I keep saying this, and I never do, to rename the talk, since you don't want to sleep like a newborn. You don't want to sleep like this age of a baby. Maybe once they're sleeping 12 hours a day, that's a better situation. But this is not the type of baby you want to sleep like. All right. Let's see. How do I? Okay, good. All right. So our primary purpose of our talk is to talk about what can go wrong with sleep? Why is sleep important? What can we do about it once sleep goes off the rails? So let's start by, why does sleep matter in the first place? And there's a fairly famous quote that essentially says, if sleep did not serve a major purpose, then it would be the greatest mistake that evolution ever made. Because frankly, we spend preferably, hopefully 8 hours of our 24-hour day, 33% of our day, asleep. Now, for many people, particularly I assume the people who are attending a talk about poor sleep, it's probably less than 8 hours, but a substantial portion of our day we spend asleep. So it really has to serve a pretty major function, and it does. It serves a number of functions. So first, why does it matter? Well, it affects the brain, it affects the body. Numerous studies have shown that a good night's sleep promotes a healthy brain. People who are sleep deprived, many of you looking back to periods of your life when you've been sleep deprived can probably corroborate that learning, problem solving, decision-making, creativity, attention, emotional well-being, those are all impaired when we're sleepy. The whole idea of the college kids who are pulling all-nighters and such is actually a pretty poor decision, because yes, short-term memory may be present after a night of no sleep or little to no sleep, although short-term memory is absolutely impaired, but the information that the person is putting and keeping in their short-term memory is only a small minority of that is actually transferred into long-term memory, into actually encoded into memory that you'll retain more than the next 24 hours. So memory is substantially benefited by sleep, particularly REM sleep, the rapid eye movement sleep, the dream stage of sleep. One of the major functions of it is to essentially serve a pruning function, where your brain takes the portions of your memory from the day and decides what's important, what should I code into long-term memory, what should I trim and just throw away in the garbage, what doesn't need to be remembered. So a lot of memory issues in terms of attention, concentration, and problem solving. So the symptoms of sleepiness are almost identical to those of ADD, attention deficit disorder. If you think about children who have ADD, what are they? They could be hyperactive, and children tend to be more hyper in their sleepiness rather than sleepy, like most adults are. but they also have difficulty attending to multiple stimuli, starting tasks, procrastinating, um, problem solving, et cetera, all the symptoms of sleepiness. And this was noticed, and there was actually a study done where, if I remember correctly, it was about 102 children were with known ADD underwent sleep testing, and 50% of them ended up having sleep disorders. So there's a big push, which I wholeheartedly agree with. Instead of just taking these children and putting them on, stimulants, controlled medications that they're going to be on for at least the next few years and potentially much longer, treat the underlying issue, treat the sleep disorder, and often you don't need to put them on these medications. How about body health? So healing, body repair, protein synthesis, breakdown and removal of waste products internal to the body, all have a significant increase in those activities during sleep. Let's see, poor sleep has been linked to increased risk of heart attack, heart disease, high blood pressure, kidney disease, diabetes, stroke, etc. Likely, at least in part, due to impairment of these healing and these natural homeostasis is the body's natural drive towards stability. These homeostatic activities are impaired in poor sleep. What else? So how about hunger hormone balance, right? I think, everyone here would probably accept that when you're sleepy, the foods that you choose are not you're not going to go for a salad, for a banana, et cetera. You're going to go for, the piece of cake, the fries, the burger, and you're going to eat more. And there are reasons for that. So the primary satiety hormone is called leptin, and the primary hunger hormone is called ghrelin. When you're hungry, you have high ghrelin levels, and when you're full, you have high leptin levels. Many of you may have heard the saying that you should eat slowly because it takes about 15 minutes or so for your body to realize that you're full. And that's because of leptin release. As the stomach starts to stretch, as it fills, your body starts synthesizing and creating leptin. And when the levels reach a certain point, your body realizes you're full, you're satiated. But it takes more stretch and more time for that stretch to stimulate enough leptin synthesis to perceive yourself being full. So that's why it's good to eat slowly. People who are sleepy have been shown to have what's called leptin insensitivity, which means that it takes more leptin to achieve the same degree of satiety. And that's why often you feel hungrier when you're well rested. And studies have shown that people who are sleepy will take in substantially more calories in a 24-hour period when compared to their well-rested compatriots. And the calories that you take in that you crave are
Debbie Kamade, don't we know her?
If we have a mute, that might be good. The calories that you take in are more carbohydrate-rich, fattier, sugary foods, and it's because your brain is looking for easy energy. You're sleepy, you're tired, and it wants energy, and that's where it looks. All right, sleep deficiency can result in higher blood sugars, partly because of increased carbohydrate risk and partly because of more labile blood sugars and insulin release. The immune system can defend against invaders. So this is all, of particular pertinence and interest to most in, the current ongoing pandemic. It's been shown pretty conclusively that a lot of, someone's just mentioning that the moderator's speaker is not on mute. Okay, so it's been shown pretty conclusively that when you're sleepy, your body does not mount the same immune response. You can actually measure titers of antibodies after a vaccine. And people have pretty conclusively shown that if you take a patient who is sleep deprived, and the studies have just intentionally used healthy controls, people who are just intentionally sleep deprived, and you give them the same vaccine as their healthy, well-rested control compatriots, that the person who is sleepy will not necessarily mount the same immune response, the same antibody levels as those who are well-rested. All right, we're getting to the end of this portion, but in terms of daytime performance and safety, so quality sleep does help daytime function. Productivity is clearly reduced in those who are sleepy. Reaction times are slower, work mistakes are higher, procrastination, inability to finish tasks, human error, much higher, numerous train wrecks, some of the, thankfully not recent, but some of the last few major train wrecks in Philadelphia were attributed to patients who had a patient specifically who had sleep apnea, who fell asleep behind the wheel. And similarly, a number of different natural disasters, including the 3 Mile Island disaster, elements of the Chernobyl disaster, have all been attributed to sleepiness. I did my training in the Midwest, and where there's a lot of long haul truckers, and it was not, unfortunately, particularly uncommon that after these gentlemen would fall asleep behind the wheel, with sometimes hopefully it was just hitting the rumble strips that scared them straight, but sometimes there are major accidents that would cause people to undergo a sleep evaluation, and that's how sleep disorders would be found. Sleep deprivation is to a degree just as dangerous as drunk driving. I mean, that's certainly within within reason. If someone who has 10 beers is obviously going to be much more impaired than someone who's sleepy. However, it's been very conclusively shown that sleep deprivation shows similar rates to impairment as someone who's had a few drinks. Driving safety or driving sleepiness, national highway data has shown that driver sleepiness is a factor in over 100,000 car accidents a year and around 1,500 deaths. So in terms of what are we looking to talk about here, why does sleep matter? That's why sleep matters, and it matters a lot in a lot of different ways. Now, what do we need to feel rested? And you'll hear me say these three a lot today. We need quantity of sleep, we need quality of sleep, and we need timing of sleep. So first, quantity, right? How much is enough? Everyone says 7-8 hours, and that really is the optimal. Now, many people live on 6 hours and say, oh, I feel fine, I've lived on 6 hours. I have kids. I've got family. I don't have the time to sleep more. 6 hours is fine, right? And I mean, many people function that way. However, they don't function optimally. This was a study where they used healthy college kids and they split them into 4 groups. They took one group and they limited them to maximum of 8 hours time in bed, TIB, 6 hours, 4 hours, and 0 hours. And what they did is over the course of 10 days, 10 days, hold on. I always forget, 1, 2, 3, 4, 5, 6, 7, 8 days. Over the course of 8 days, they did 2 things. They every day had them complete what's called the SSS, the Stanford Sleepiness Scale. And essentially what that is a measure of how sleepy the person perceives themselves to be at that time. How sleepy do you feel at this moment in time? And they had them do a task called a psychomotor vigilance test, PVT. And essentially what that does is the person is sitting in a relatively dark room, no external stimuli, and with essentially their head in a cubby. And every time there's a sound or a flash of a light, they have to hit a button. So performance is measured in PVT lapses. So high is bad because every time the higher the number goes, the more of those stimuli they miss, the less attentive or the more sleepy they are. And what this study does, if we look at this, is on each of these days, day 1, 2, 3, 4, 5, 6, 7, 8, how did they do in terms of psychomotor vigilance test, PVT lapses, and how sleepy did they perceive themselves to be? Now, the 0 hour time in bed, they only monitored them for 2 days because that's cruel and unusual punishment. And they did exactly as well as you'd think. They felt exactly as sleepy as you'd expect. And they did horrendously by 36 to 48 hours in, they did horrendously on the PVT test. The 8 hour time in bed did pretty well. They felt good, they felt alert, and their performance was decent. The one thing to point out here, though, is that you can see this is not a flat plateau of a graph. They were doing worse every day towards the end. And you have to remember that college kids, or that the 8 hour optimal sleep hour is a bell curve, right? There are people, in younger ages, so there are people who need 6 hours, people who need 7 hours, 8, 9, and 10. Most people who say or perceive themselves to need 6 hours say, oh, I'm just a short sleeper, I don't need that much. Truly do, they're just subsisting on less. There are also changes based on age. So college kids, teenagers and college kids generally need more in the realm of 9 to 10 hours of sleep on a nightly basis, which most with teenagers would say they don't get, but that's the amount for optimal sleep. So 8 hours time in bed for these kids was actually a relative mild sleep deprivation. So they felt good, but they did reasonably well, but not perfectly towards the end. Now the 6-hour group and the 4-hour group, they felt pretty similar. They both felt sleepy, and they were getting more and more sleepy as the days went on. But the person who was getting 6 actually felt close, fairly similar to that who was getting 4. However, if you look at their performance, the 4-hour time in bed group was doing worse and worse and worse, almost linearly, going from day 0 to day 8, while the 6-hour time in bed group was starting to level off. And someone who was getting 4 hours time in bed by 8 days was doing as poorly on the psychomotor vigilance test as those who had 0 sleep for 48 hours. So this is both a measure that we are not very good estimators of how much sleep or how sleepy we are, because even though the 4-hour and the 6-hour group felt the same in terms of alertness, the 4-hour group was performing substantially less. That's why people are very poor, unreliable historians in terms of, are you too sleepy to drive? Can I make it this last mile as my head is starting to nod? And also the fact that, even 6 hours is, which many people subsist on, is not enough to, be at peak performance. How about medical residents, right? There are kind of our poster children for sleep deprivation. And in this study, what they did is they tested a group of medical residents for narcolepsy. Now, narcolepsy is a condition where people do not have enough of a specific neurotransmitter in the brain that's responsible for keeping you awake. Hypocretin or orexin, same thing, just different names. And these people are pathologically excessively sleepy because they just don't have as much of that neurotransmitter keeping them awake. Now, this is a test called the multiple sleep latency test, where you put the person in a sleep lab and you do 5 20-minute nap opportunities throughout the course of the day, often at 10 a.m., noon, 2, 4, and 6. And you see how quickly do you fall asleep in the middle of the day during a monitored setting. This red line at about 7 to 8 minutes is what's considered more sleepy than someone should be, pathologically sleepy in the degree of narcolepsy. And up here is normal. Now, these medical residents were ostensibly healthy. They did not have narcolepsy. They didn't have other sleep disorders. They were excluded from that. When they were getting 8 to 9 hours, they were falling in the normal range. But as they dropped down to 7 and even down to 6, they were scoring in terms of sleepiness in the narcoleptic range. And the other important thing is that even though this test, you can clearly see as the person administering the test that the brain was falling asleep, that they were falling asleep, because they have EEG attached to measure brain waves. The majority, or not the majority, but almost, a very subtle minority of these patients were unaware that they had actually fallen asleep. Again, to belabor the points, we're very poor estimators of whether we're tired and whether we, doze off briefly at times. So that's why does sleep matter, right? Now, what about what do we do about it? So insomnia is the most common cause of sleep deprivation. If we set aside just behaviorally induced insufficient sleep, meaning I just have things to do, I'm not prioritizing sleep, I'm staying up late. So what do we do about insomnia? Well, first it matters what kind of insomnia do you have, because not all insomnia is created equal. Insomnia is generally broken up into initiation insomnia, difficulty falling asleep; maintenance insomnia, difficulty staying asleep; and termination or end of the night insomnia, where you wake up and that's the end of the night of sleep for you. The distinctions matter because certain things cause one, certain things cause another, and some cause multiple. It's not terribly common that insomnia is isolated to just one of those things. So don't, sit there, for those of you with insomnia, say, oh, well, I've got a little bit of each, this, that, and the other, so which is it? Well, often there's a bit of overlap. So you have to, when we're looking at, patients with insomnia, you have to determine which is the major component. So first of all, and before we go any further, I should just say, in terms of what common things might cause one, the next, and then the next, we'll start with end of the night insomnia. Now, that is commonly because of, grief, depression, anxiety, because with that end of the night insomnia, often you've gotten just enough sleep that you're no longer, having sleepiness and exhaustion fueling you to sleep, but you wake up and all of those things on your mind, stresses, anxieties, worries, take over, and that's the end of the night for you. So classically, although of course not always, those underlying mood issues, stress, anxiety, depression, etc., grief, are the cause of most common cause of end of the night insomnia. Beginning of the night insomnia is more commonly what's called psychophysiologic insomnia or active mind insomnia. In that case, it's often either a maladaptive pattern where the brain associates the bed in the bedroom with a place of stress. When someone has been sleeping poorly for a long time, often the bedroom can not be this comforting oasis, but instead this source of stress, this battlefield of trying to sleep and not succeeding. So often, people with this kind of insomnia can feel extremely sleepy on the couch, but then when they go to bed, all of a sudden they're wide awake and they're awake for hours. So that's the most common cause of this beginning of the night insomnia, although certainly not the only one. More maintenance insomnia, difficulty maintaining sleep, then we really have to wonder, is there a specific sleep disorder waking the person? And we'll talk about that in a minute. So first of all, just basic sleep hygiene, right? What are good sleep habits? What bad habits should we eliminate? Caffeine, right? I am just as guilty of that as everybody else. I'm sitting here at 6:23 p.m. having my cup of coffee, which is a terrible idea. Caffeine stays in the system much longer than most of us would suspect. So this is very much a do as I say, not as I do in regard to the cup of coffee I'm having right now. But be aware that caffeine can stay in the system for 6 to 8 hours from the cup. So you really want to limit when you drink caffeine, and that doesn't just have to be coffee. It can be tea, it can be sodas, any of those things could be an issue. So generally, if someone is having difficulty falling asleep, frankly is why it's okay that I do, because I don't have insomnia, so it's okay. But you really want to limit the caffeine after about 2 o'clock, if at all possible, and preferably before that. Now, what about napping, right? There's this very common maladaptive thought process that can develop in someone who's been sleeping poorly, where essentially, okay, I'm not sleeping at night. I need to get some sleep. Let me get it during the day. I know, it's probably not a great idea, but I need to get some sleep, right? Dr. Dupre just, spent 20 minutes talking about how important it is that I get some sleep. Well, yes and no. So, sleep is good, but sleeping during the day when you're sleeping poorly at night is not, because you develop this vicious cycle where you sleep poorly at night. And so because you sleep poorly at night, you're sleepy. And because you're sleepy during the day, you sleep. But because you sleep, now you sleep poorly at night. And it just becomes a vicious cycle and essentially a feed forward loop where the one feeds the next. So, one of the first things that we do is say, all the napping gotta go. Even someone who's just, say, resting in bed with their eyes closed. People with chronic pain often see the bed as the sanctuary where they stay in bed and they know they're not sleeping, they're not intending to sleep, but they're lying there in bed trying to relax and rest and escape from their pain in that way. The problem is that even when you're awake in bed, the more time you spend awake in bed, the less your brain associates the bed and the bedroom environment with this is where sleep happens. This is it becomes this place of where your brain says, oh, this is where I'm awake. I watch TV, I go on my phone, I do this, I do that. And you really want your brain to know that the bed and the bedroom environment is for sleep, intimacy, nothing else. Clock watching, right? So I'm going to use a little bit of hyperbole here and say that there is not a single person in the history of humanity who has fallen asleep faster knowing what time it is. And it's just frustrating. Now, have there been? Probably. But the vast majority of people, for the vast majority of people, clock watching, particularly checking the clock in the middle of the night, okay, it's been 45 minutes, it's been an hour, it's 2 hours, I'm still awake. You wake up and you check the clock and say, oh, it's 3 a.m, I have to be up at 6. I got to get to sleep now. Otherwise, I'm only going to be able to get 3 more hours of sleep and, yada, yada, yada. It just becomes this source of frustration and stress. And so, getting the clock out of there, turning it around if it's an alarm clock, setting an alarm on your phone and, getting any other clocks out of the bedroom, taping over the cable box, etc., is important for people who, find that they're compulsive clock checkers, clock watchers throughout the night. How about alcohol and nicotine, right? So alcohol, the idea of the nightcap. Alcohol is a dirty drug, meaning it is both stimulating and alerting. The problem is that stimulating and depressing. from a nervous system standpoint. So that initially in the first 4 hours or so, the CNS, central nervous system depressant effects win out in terms of potency. So that's why often if someone has a drink, they're better able to fall asleep, because the depressant effects, the turn down your nervous system, fall asleep effects are more potent. The problem is that after about 4 to 6 hours, that switches, and the depressant effects are generally gone, and now you're left with the alerting effects. That's why someone who drinks themselves to sleep, or habitually has a few drinks every night, can find that they often wake up 3 to 4 hours into the night, and either that's the end of the night of sleep for them, or they're waking up frequently for the remainder of the night, because even if you are able to fall asleep despite that, it lightens the sleep itself and reduces the amount of outside stimuli, sound in the external environment, pet walking on the bed, et cetera, that it would take to wake you. How about nicotine? So people who smoke often smoke in the evening. You wake up and you go to have a cigarette because the idea is that, well, it's relaxing, right? And I want to be able to relax myself so I fall asleep. The problem is that the nicotinic acetylcholine receptor, the receptor in your brain that nicotine binds to, is an alerting neurotransmitter. So generally people who smoke in the middle of the night or smoke to relax are not relaxed and sleepy. They are relaxed and awake because the itch has been scratched. The relaxation comes from the meeting the need, so to say. So generally smoking at night is not helpful for sleep because you end up relaxed and awake rather than relaxed and asleep. Besides every other reason, it's not a good idea to smoke. How about the bedroom environment, right? So just statistically, people are much more likely to sleep and sleep well and achieve more deeper sleep if the bedroom is cool, if it's quiet, maybe a little bit of white noise, but definitely no sound, no TV, no electronics, no phone. And for people who are shift workers, blackout curtains can be extremely helpful in that regard. There are many people who sleep with the TV on to help themselves fall asleep. And that for people who have a lot on their mind, that can help to distract the brain. But the problem is that it's fairly common that the sound in the show, the sound levels in the show that the person may be watching are different from the commercials. There are laws about it where let me remember the details here. The sound in the commercials cannot be louder than the loudest sound on the television show. So on one of these, what's on often at 2 and 3 in the morning, Law and Order and things like that, right? Well, the conversation may be quiet, but all the gunshots and things like that, the people who make the commercials are limited to making the commercials, they're allowed to be as loud as that. And it's not uncommon on sleep studies and things like that, where we'll have the person asleep in the room, the TV will be on. We don't like to have the TV on during a sleep study, but if it's a deal breaker, we'll allow it. And we'll see that there's a loud sound on the TV as it cuts to a commercial, there's an explosion, a gunshot, whatever, and then all of the person wakes, and as soon as by the time they're conscious of the world around them and flipping over, the sound is back to normal. So they have no idea what woke them. Meanwhile, it was the sound on the TV. So generally, the TV is not a good thing for sleep. Someone mentioned a timer, and that's a good middle of the road option. If someone says, "Listen, I need to have something on to quiet the mind. It's not just left there in the dark and quiet." I'd say the best option would be a white noise machine, nature sounds, that kind of thing. However, if someone needs to listen to something, then a TV timer would be a good kind of middle of the road compromise there. All right, so so that's the bad habits. Now, what about the good habits? What should we maximize? So worry time for people who are worriers, who have a lot on their mind. You've got something going on. You're planning for your son's wedding or something like that, and there's a lot to do. Often setting aside half an hour to an hour before bed to get that out of your system is enough. Make lists. There is a mental phenomenon where when your brain knows that something has been written down, it's been put on paper, a list has been made, etc., often your brain checks that off its own internal list and stops worrying about it, or at least doesn't spend as much time and mental volume worrying about it, because it essentially consciously and subconsciously knows, okay, it's been addressed. So setting aside that worry time exercise. Now, exercise in the evening, particularly before bed, is not a great idea because you can sometimes rev yourself up. However, any exercise, even right before bed, is better than no exercise in terms of sleep continuity and depth. We already talked about bedroom temperatures. Mental distraction techniques. So counting sheep doesn't work because it's just way too easy. 1, 2, 3. It only takes up so much of your mental bandwidth. So you need to do something that's a bit more challenging, but it's still boring. So 3 options. One would be counting down by 3s or by 7s from a high number. 9,552. You want to pick either 3s or 7s depending on what do you feel is going to be doable without a lot of mental effort, yet also engage you. You also need to not worry too much about, did I get those calculations right? Frankly, it doesn't matter if you subtracted 6 instead of 7, just refocus and stick with it. Another option would be to count upwards from A to Z, thinking of 3 unrelated words that all start with that letter. So A, aardvark, apple, avocado, B, and go from there. The idea being to engage your mind, not leave yourself with extraneous mental processes to take up your mind. Now, someone mentions, why count down if you have to think about it? Isn't the purpose to not think? The purpose isn't to not think. The purpose is to not focus on the intricate details of your life, of your mind, of everything that's running through your head and keeping you to fall asleep. So these are tasks that are fairly mindless. They require you to attend to it, to think, where am I? Either counting upwards by letters or counting downwards by numbers. They require you to take that information, do something with it, focus on it. Yet at the same time, the exact intricacies aren't terribly important. Did I get that calculation exactly right that one time? Doesn't matter too much. But also don't leave you with the mental bandwidth to think and worry about all the other things that are going on in life. They're also frankly boring, which is also not going to keep you up, having fun. All right, so medications versus behavioral strategy. So everything we've been talking about is behavioral. What about medications, right? So everything has their place. Medications, they may be effective in the long run, and they are for some. The risks, so you've got tolerance, you've got dependence, and you've got side effects. From a behavioral standpoint, you've got relaxation training, things like yoga, meditation, guided imagery, something called progressive muscular relaxation. You've got cognitive therapy, which at its utmost, most oversimplified core is the idea that you get in bed and you don't worry about what happens if I don't fall asleep. Often someone who's been sleeping poorly for a long time, I said earlier that the bed can become a battlefield. People get in bed and all of a sudden start worrying, what if I don't sleep? I'm going to be exhausted. I'm not falling asleep. And you can develop this almost, mental spiral. And the idea of cognitive behavioral therapy, CBT, for insomnia is that you get in bed with the thought process that it doesn't matter if I fall asleep. If I fall asleep, great. If I just rest, close my eyes, eventually doze off, well, that's fine too. Yes, I didn't sleep that well yesterday or last week, but I functioned. I went just fine. So I'm going to put a kibosh on the questions. If you've got a deep burning question that must be answered now, you can answer it, but I'm going to ask that people save the questions for the end. So got derailed there. Yes. So, and the idea, almost counterintuitively, the less you worry about falling asleep and fight to fall asleep, often the easier of a time you have falling asleep. And the reason for that is that you've got 2 halves of your nervous system. You've got the fight or flight and the rest and digest mode, also called your sympathetic and your parasympathetic nervous system. They exist in a balance. This being fight or flight, sympathetic, this rest and digest, parasympathetic. Now, everyone lives their life in a different status quo between the two. billionaire surfer on a beach in Hawaii is living their life like this. The type A Wall Street, whatever, is living their life like this. Most of us are somewhere around here. And the balance varies over the course of the day. So as you're living your daily life, you know, when you're at work and such, you're more like this. As you're relaxing, going to bed, etc., you want to be more like this. And the idea is with these if you go to bed with the thought process of, and again, this is a drastic oversimplification of, you know, the idea of cognitive behavioral therapy, but the idea is that if you go to bed with the idea, it doesn't matter if I fall asleep, I'm going to relax, I'll be rested, I'll rest, it'll be okay. Often your brain starts to do this rather than, oh no, I'm not going to sleep. What if I don't sleep? Blah, 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 going into this whole downward spiral. Let's see. Now, stimulus control. So similarly, I mentioned that the bed can kind of become this battlefield. And if you think of the analogy of Pavlov's dog, right? Pavlov's dog is the kind of college kid classical example of conditioning. What Pavlov did was he trained these dogs, and what he would do would be to ring a bell. And when he rang a bell, nothing happened. But he attached a salivary gland monitor, which would measure how much they salivated. And what he would do would be to feed them. And every time he fed them, he rang a bell. And by, you know, the end of whatever period it was, when he rang the bell, just the ringing of the bell would trigger the salivation, even without the food. And that's conditioning. We humans are just as prone to conditioning as animals. And what you want, the conditioning you want, is that the bed in the bedroom is the stimulus, and that when you enter the bed, your brain shuts down and goes to sleep, because that's the conditioned response. When someone's been struggling to sleep for a long time, and particularly when there's a lot of frustration involved with the bedtime, instead the stimulus is still the bed, but often the conditioned response is awake, awake and worry and stress and frustration. That's why often people can be tired, who've been sleeping poorly, can be sleepy at somewhere else in the house, dozing on the couch or what have you, and then they go to the bed and all of a sudden they're wide awake, and it's because that conditioned response. So the idea behind stimulus control is to remove or limit as much time awake in bed as possible. So for instance, if we're starting stimulus control on someone, what we'll do is tell them, if it feels like around 30 mental minutes has passed. Now, why do I say mental minutes? Because we don't want them clock watching. Doesn't matter what time it is. But if it feels like around half an hour has passed, we tell the person, get up, leave the bed. By that point, if you're wide awake, the likelihood of you falling asleep in the next half hour is probably fairly low at this point. So get up, do something boring, low light, low intensity, not terribly productive. You know, you don't want to do laundry, you don't want to clean the house, you don't want to get up and moving, cook, clean, any of those things. You don't want to watch TV or do things that are, you know, a lot of blue light, electronics should be avoided because blue light is very alerting. Generally, something mind-numbingly boring is a good option. So if your spouse reads something that is not particularly interesting for you, that would be potentially a good option. You don't want to read something interesting because now you get invested and lost in the book. Some people can do, you know, word finds, crossword puzzles, things like that. Find something that's works for you. Do that until your eyelids start to get heavy, and then go back to bed and rinse and repeat. So cognitive therapy for insomnia versus hypnotics and sleeping pills, right? So they are probably equally effective initially, although hypnotics, sleeping pills do work more quickly. So, you know, people like them because they scratch the itch. They, you know, if there's going to be an effect, they get it quickly. The problem is that the effects wear off often, as the person becomes tolerant, and two, if you stop them within pretty quickly, within a period of weeks, the effect things go back to normal if they're stopped. So if you're starting someone on sleeping pills, it's sometimes going to be for the foreseeable future, and whereas the effects of the cognitive side can last for months to years. Someone asked on medication, don't take it on Friday and Saturday since they don't have to work the next day. Is that a bad idea? No, that's not bad. So, you know, in terms of avoiding tolerance, taking drug holidays, days without it are generally a good idea, because that can at least do a little bit to help avoid tolerance from developing. Let's see, management of take-home. So, okay. So, you know, I've removed from this talk, I used to talk about, you know, the intricacies of the different medications, sleeping pills and things like that. I guess the only thing I'll really mention in that regard is that what are called the Z drugs, that's zolpidem, which is Ambien, ezopiclone, which is Lunesta, and zaloplan, which is Sonata. About a year and a half ago, a fairly interesting study came out which showed that long-term use of those medications, well, I want to be the details matter in this one. So what they did is they asked people, thousands of patients, a series of questions, and one of them was, do you regularly use sleeping pills, specifically those medications? And people who reported yes to be regular habitual users of those medications were statistically more likely to also have cognitive impairment and or dementia. So there is a push now for people who are taking those Z drugs, again, zaloplan, which is Sonata, zolpidem, which is Ambien, and ezopiclone, which is Lunesta, to try and switch people off of them because of that. Why is that the case? We don't know yet. It hasn't been clearly determined why that effect seems to be present, but it's concerning. Let's see, the newer medications, and there are some newer medications for sleep, generally are a little bit better. There's less tolerance, less withdrawal effects if it's stopped. So less side effects in general, but the benefits are still modest. Dose escalation and tolerance can still happen. Cognitive behavioral therapy is effective as medication. It should be the first time treatment or first line treatment for chronic primary insomnia. And drugs are useful if CBT is ineffective, unavailable, or declined. Last question I'll answer on the subject before tabling questions for the end is that define long-term use, there was no definition on the study. So there's no answer for that, unfortunately. They did not break it down into how long people were on these medications. All right, so disruptors of sleep quality, right? We've talked about the different types of insomnia, difficulty falling asleep. Now we're into the difficulty maintaining sleep or less restful sleep side of things. So the classical poster child of this is sleep apnea. We'll go into that in a moment. There are other conditions that also disrupt quality of sleep, periodic limb movements of sleep, which is reflexive leg movements during sleep that can either bother the bed partner or wake the person. You've got what's called environmental sleep disorder, which is essentially it's tough to sleep when you've got pets walking all over you, you've got a bed partner snoring the roof off, you've got the garbage truck outside making a racket, etc. Shift workers can have trouble sleeping with the sun shining in, that kind of thing. And then medications, there are plenty of medications that can disrupt sleep. So sleep apnea. Sleep apnea is a condition where people repetitively pause in their breathing during sleep. This is kind of the poster child for sleep apnea. This is the airway. You've got your nasal airway and your oral airway, which then come down into your primary airway going down towards your lungs, and a thick neck, a big tongue, a long, low-lying soft palate and uvula. All of those things can narrow the space back here. This is the optimal situation. You can see here that there's plenty of room back here, whereas on this person, not so much. Now, sleeping on the back can also make this worse because the jaw is the most mobile portion of your airway, right? So when you sleep on your back, if something's gonna move, it's gonna be your jaw falling backwards with your tongue falling back into your airway as well. Why does it matter? Well, so a couple of things, and it really depends on severity. Any amount of apnea can disrupt sleep, wake the patient, make sleep restful. Mild sleep apnea increases the risk of developing high blood pressure. And when someone has high blood pressure, it tends to run higher and be harder to control. Moderate to severe sleep apnea can not only increase that same hypertensive risk, but can increase the risk of heart attack and stroke. It does not cause, but it can worsen or exacerbate atrial fibrillation and irregular heart rhythm, diabetes, and high cholesterol. The effect, if we're stratifying the potency of effect, the diabetic and high cholesterol effect are the weakest associations of the six up here. It's not only a condition of the overweight. It's classically thought to be a weight-related condition, and certainly weight gain is the single most potent risk factor for the development of sleep apnea. But there are plenty of people who are rail thin, who are born with extremely narrow airways like this, or just somewhat narrow airways, and that someone who's rail thin but with a crowded airway can have just as much apnea as someone who is who's overweight. What are the signs and symptoms? Snoring, snorting, gasping. The bed partner says, honey, I see you, stop breathing in your sleep. Often there's a big drastic sound at the termination, a kind of sound, but not always. They can be very subtle. Multiple awakenings, frequent urination at night, nocturia. Why would a breathing effect cause you to wake up to use the restroom? Well, when you wake up at night, your brain does a quick mental inventory. And part of that involves, do I need to pee? And if your bladder is slightly full, your brain says, oh, that must have been what woke me up. So you go and do your business and you go back to bed, and the cycle repeats throughout the course of the night. Even if it was something else entirely besides the need to urinate that triggered the awakening. Non-restorative sleep, waking up feeling unrested or tired, becoming tired early-ish during the day. Morning dry mouth, sore throat, or headache is often indicative of mouth breathing, which is often a compensatory mechanism to try and get as much air down the airway as possible. And daytime sleepiness. So someone mentions prostate issues causing bathroom visits. So sure, absolutely. As the prostate gets bigger, frequent urination can develop. So absolutely that can do it. However, I would say while many episodes of nocturia, frequent urination at night in, say, a middle-aged or older man are related to the prostate, it is not all prostate. Not all that pees at night is prostate. What do we do about it? So CPAP is the classical treatment. It's considered the gold standard because it works. What is CPAP? This is an example of a CPAP machine. Sits by the side of the bed, pulls some of the air in the room into it, puts it under pressure, goes through a hose that goes to a mask that you wear while you sleep. And that air goes down the airway and acts like a pneumatic splint. It essentially is like the sport beams in a mine shaft. It holds things open and the airway can't close because that column of air is there. We'll come back to the CPAP in a second. What else is there? You've got mouthpieces, oral appliances, positional therapy. Apnea is often worse on the back, so potentially keeping someone off of their back may be an option. Provent, which is essentially a one-way valve where you can inhale but can't exhale. So that air that you try to exhale backtracks down the airway and acts almost like kind of a weak CPAP. Surgery on the back of the airway, Inspire, which we'll talk about, and weight loss. So CPAP, no one loves the idea of CPAP, right? The vast majority of people who come to us and who end up on CPAP are not, terribly enthusiastic about the idea of wearing a mask. That said, often, people can adjust to it much more easily than they often assume, although certainly some people do struggle, there's no question. There's a big trend in masks. Masks, CPAP is big business because there are millions of people out there on CPAP. And, these companies are competing to make the smaller, less invasive, more comfortable masks. Your three basic types are full face, nose and mouth masks. They are nasal masks, and they are little masks that go up against the nose. And they're all equally effective as long as your mouth stays shut. If your mouth hangs open at night, then you need something that either covers both or to keep the mouth closed. Mouthpieces. So a mouthpiece, generally what they do is they hold the jaw forward. They all work via the same idea, but by different mechanisms. That is to hold the lower jaw forward in relation to the upper jaw, somewhat like this, with the idea being the tongue, as you can see here, comes off the back of the jaw. So by pulling the jaw forward, you pull the tongue forward. They're not as reliably effective as CPAP, but particularly in people with overbites where they put their teeth together and their teeth come together like this rather than like this, they can be very effective. There was a study done in New Zealand about 10 years ago at this point, where they took patients with severe sleep apnea, where we know oral appliances, mouthpieces are not going to control the apnea completely. It's been repeatedly demonstrated. And they took these patients with severe apnea who couldn't or wouldn't use CPAP. They split them into two groups. One group, they just followed them for 2 years. And they looked to see what were the rates of uncontrolled high blood pressure, heart attack, and stroke. And they matched that of the known untreated severe sleep apnea population. They took the other half and they made these mouthpieces for them. They adjusted them, repeated a sleep study while wearing one, and showed that yes, the apnea severity was reduced, although not down to the not completely controlled, and they followed them for 2 years. And they showed that the rates of those cardiovascular endpoints, heart attack risk, stroke risk, uncontrolled high blood pressure risk, were substantially reduced, although not down to the non-sleep apnea population. So essentially, what that boils down to is these, even for people with severe apnea, even if they're not going to control the apnea completely, they are a reasonable temporizing measure. They do reduce the risks somewhat. So that's sleep apnea. Now, not all that disrupts sleep is sleep apnea. This is the next most common. It's something called periodic limb movements of sleep. This is reflexive leg movements during sleep. Often what's called a triple flexion response, where the ankle twitches, the knee bends, and the hip goes up. It can be anywhere from just a little subtle twitch at the ankle to a much more violent flinging motion of the leg. Do they matter? Sometimes. They are extremely common. Everyone has a few here or there. Anything less than 5 times an hour is not likely to be clinically significant. However, if the bed partner is noticing repetitive kicking, they're probably drastically more than 5 times an hour. The thing is, so everyone's got a different threshold for awakening. And there are many people who have frequent leg movements throughout the night that don't disrupt the person's sleep in the least, but probably bother the bed partner to high heaven. And there are people who kick themselves awake all night. So periodic limb movements only matter if they are disrupting the person's sleep or if they're disrupting the bed partner's sleep. Environment: pets, spouse snoring the roof off, temperature, noise outside. And the solution is, it sounds straightforward, although it often isn't. It's address the underlying issue. Timing of sleep, right? So timing matters. What do you need to be rested? You need quantity, quality, and timing. So timing. If you try to sleep during the daytime, look out this window, you're probably not going to sleep all that well. Now, technically it's 6 a.m. apparently. We'll pretend it's 6 p.m. and wide awake. These people probably wouldn't sleep all that well. So if most people try to sleep during the day, they're not going to sleep as well, which is often why people who are shift workers may struggle to acclimate, particularly if they switch back and forth from night to day shift and vice versa. There are some people, particularly teenagers, 30% of teenagers have what's called delayed sleep phase, which we'll table that. I just want to say, so there are certain periods of the day when we're naturally have an increased sleep propensity. Sleep propensity is lowest at noon and 6 p.m., highest in the trough, and a little higher in the trough between, and then increases as you approach midnight and then drops down after that. Some people, however, do not have that same pattern. This here is an example of sleep propensity for people with a typical what's called sleep phase, where they often get the most tired around midnight and wake up around 8. Now, majority of people are maybe a little bit shifted forward from this, but this is just an example. Delayed sleep phase. So I started to talk about teenagers, right? 30% of teenagers have some degree of a delayed sleep phase, which is essentially the person does not start to become tired until later than most. And similarly, the brain doesn't start to wake up until later than most. That's physiologically why teenagers classically want to stay up all night and sleep all day. And the opposite is true as people get a little older, above the age of 75. It's more likely that people shift in terms of what's called an advanced sleep phase, where they get sleepy early and they wake up early. So how do these people present? Well, they're particularly tired in the evening, but they wake up 3, 4 in the morning, unable to return to sleep. This is back to that end of the night insomnia. I said classically it's anxiety, grief, depression, etc., but it very well could also represent advanced sleep phase, where this internal schedule is shifting forward. Back to the delayed sleep phase. So people, when they attempt to operate within their natural clock, where their body wants them to operate, they do better. There were studies done in terms of delaying. There have been a lot of studies done in terms of the effect of delaying start times in schools, and just minor effects. So delaying in the school in Rhode Island, a school district in Rhode Island, they delayed start times by 25 minutes. And they found that substantially more kids increased their sleep hours beyond 8 hours. There was a study in Minnesota schools by delaying start times half an hour from 7:30 to 8. ACT performance, classroom performance, patients' subjective measures of how of emotional well-being all improved drastically. Motor vehicle accidents on the way to school dropped substantially. Tardiness, substance abuse, depression, consumption of caffeinated beverages all improved substantially. Now, why is this not taking the nation by storm? Well, after school programs, athletics, after school jobs that rely on people who will work for minimum wage, like most high school kids, et cetera, often rely on these these people to be, these kids to be out of school at certain times. And if the later you start, often the later you have to end. So it eats into those things. So there is substantial pushback on among a lot of districts in terms of this. Now, actually, I realized in the sleep apnea things, I said I was going to talk about Inspire, and then I didn't. So I just want to quickly go back to that, and then we'll have some time for questions. Inspire, some of you may or may not have seen commercials for it. They're advertising like crazy on TV and radio and such. Their slogan is something about treat your apnea with the push of a button. And essentially what they are is an implanted nerve stimulator. And essentially it's pretty much a pacemaker. And what it does is you turn it on when you go to bed, and it senses when you take a breath. And every time you take a breath, it stimulates the hypoglossal nerve that leads to your tongue to stiffen your tongue and keep your tongue from falling back into your airway. So to keep you more like this instead of like this while you sleep. The good things, so in terms of effectiveness, it's the most effective thing that is not CPAP. CPAP is around 95% effective. Inspire is about 65% effective. Well, that doesn't sound great. However, nothing else is that close. So, it's a good option. The biggest drawbacks are really that it is a procedure. You have a pacemaker, what amounts to a pacemaker, implanted in the chest wall. So it is not a major surgery, but it's not a negligible surgery. And two, you cannot, when it's in place, have an MRI of your chest or your abdomen. And if it's removed, which is really not that big of a deal to remove it, they sometimes can't take out the wires that go to that nerve. And if they can't take out the wires, now you can never have an MRI of anything ever again. So that's as a neurologist, which is my background, and neurologists like to MRI things, the possibility of removing that is that capability is a bit of a limiter for me. Okay, so that is our talk. It is now time for questions, concerns, thoughts. Feel free to speak up in the chat or verbally, preferably in the chat, because that lets us moderate things a little bit more easily.
Okay, thank you. So if anybody has questions, please feel free to either put them in the chat box or ask Dr. Dupre.
Okay, well, that's a good sign. All of your deep burning questions were answered. Okay, great. All right, so we've got a few questions here. So we'll go in order. So the first one I have here is what are my feelings on taking melatonin every night? So melatonin is generally fairly benign stuff. There is a concern that could you be suppressing the person's internal melatonin synthesis, because melatonin is a natural chemical that your brain makes as a stimulatory or as a signal to the rest of your body that now is when you should feel sleepy. That's what sets a majority of your sleep timing, that circadian rhythm, that advanced and delayed sleep phases, when your brain starts making melatonin. Generally, the dose, anything below 10 milligrams is not likely to substantially affect that. So that's not a big deal. In terms of children, I would not recommend melatonin in kids, because there is some evidence that long-term use of melatonin can suppress pubertal development. Now, that was data taken from rat studies. No one has ever done those studies in humans for obvious reasons. However, it's just generally a good idea to avoid it in case that data does correspond to humans as well. But generally, it's pretty benign stuff as long as it's not making the person sleepy during the day. There are some people who are profoundly affected by melatonin and some people who don't notice a single thing. 10 milligrams would not be my starting dose. If I was starting, I would probably tell someone to start at either 3 or 5 milligrams. I mentioned a device in the mouth. What about a night guard? So night guards are only useful for grinding, for bruxism. They don't do anything for sleep apnea or really anything besides bruxism, where I suppose holding your teeth in alignment. The oral appliances for apnea do double duty for grinding. So these function as a night guard, a grinding appliance for bruxism. Bruxism appliances do not treat other things. Next question. What is the best method for day-night shift workers to slip back and forth, or to flip back and forth? Don't do it. No, that's a facetious answer. People can't avoid it, obviously. There's no good answer to that. So you really want to establish as much consistency as possible. So yeah, the longer the time on a shift, the better. So, you know, people who go back and forth, 2 days on, 3 days off, et cetera, that's terrible, because just as soon as you're starting to adjust, you're going back in the other direction. So for instance, 1 month on, 1 month off, et cetera, or 1 month day, 1 month night, et cetera, is the best, as much as you can. If you must flip back and forth, you want to maintain consistency. So someone who's 3 days nights, 4 days days, and that kind of thing, try to live your night, even on your off days, try to stick to the night shift schedule, because the body really is not configured to shift that back and forth well. Now, there are things that you can do for night shift workers who are coming home and trying to sleep. So sunlight is one of the most potent stimulators of alertness. And so you really want to avoid sunlight hitting your retinas. There is a direct connection between the back of the eye and the pineal gland that stimulates stimulates melatonin secretion. It's getting late. In an inhibitory fashion. So that sunlight hitting your eyes on the drive home from work overnight decreases what you want, your natural melatonin synthesis. So, you know, dark sunglasses, going straight to bed when you get home. Don't take care of all kinds of tasks. Don't go do errands and shop during the daytime. Go straight home, be in the dark, blackout curtains, that kind of thing is the best option. Next, women are more inclined to insomnia. Does that factor into long-term use of Ambien? So there are a couple of ways that I can interpret that question. So are women more likely to use Ambien in the long run? Sure, because you know you're correct that women are statistically more likely to report insomnia. So is a woman more likely to be on Ambien than a man? Sure, absolutely. Now the question is, does that factor into long-term risk of use of Ambien? And nobody knows. So we don't at this point well understand why that increased risk of cognitive decline is present or seems to be present with long-term use of Ambien and related medications. And to my knowledge, no one has stratified it by gender at this time. Comments on bedroom temperature. So cool bedroom temperatures are generally perceived to be best and most comfortable. Generally, people like to sleep in a cool temperature or cool room with a warm blanket. The only exception I've ever met to that was a few people who generally were born and raised in much warmer climates and then moved to this area. Next question, waking mid-sleep, having no problem going to sleep around 10, waking up between 2 to 3, staying up for 2 to 3 hours, and then back to sleep. So there are a couple of ways of looking at that. So that raises the question, is there something that's triggering the awakening and now you're awake? That tends to fall more in the maintenance realm of things. The other thing that could potentially be developing with that prolonged middle of the night awakening is what's called a conditioned arousal, which is essentially everybody wakes up. Everybody does. Even people who say, oh, I don't wake up, they wake up. What happens is that they just flip over and go back to sleep so quickly that they weren't even aware of it or don't really have much of a recollection of it. What can happen in a conditioned arousal is you wake up and the brain essentially expects to wake because you've been doing so. And so your brain wakes up and says, oh, there it is, now I'm awake, and your brain activates. And so the interventions there are similar to those I talked about that beginning of the night insomnia, essentially teaching the person, no, instead you just flip over and go back to sleep. Do people get used to melatonin? You should stop and then restart. Well, that falls into the same tolerance. Melatonin is a sleeping pill by another name. I mean, it's a gentle sleeping pill. It's more benign. The side effect profile is less, but you can become just as tolerant to melatonin as you can to anything else. Thank you. Someone said thank you. So I'm happy to help. Frequent bathroom runs at night is a sign of sleep apnea, so it certainly could. We talked about the fact that when you wake from all-cause awakenings, your brain often does a quick check to see if there's urine or anything else, and if there is, then you go take care of it. Meanwhile, if you hadn't awoken from an apnea or something else, you might have woken up hours later with a much more full bladder. How much time is needed for the heart and blood vessel repair related to sleep versus nap? So I'm not going to answer the question sleep versus nap for a couple of reasons. One, I don't want to encourage napping. Brief power naps, if someone is exhausted and just needs a quick power nap to function, if they're going to potentially drive into a wall, if they drive home, etc., then sleep. Don't drive sleepy. But if you must nap, 15 minutes maximum, quick power nap, because otherwise you're eating into your ability to fall asleep at the rest of the night. How much time is needed? A rough answer is 4 hours. Beyond that, it really depends on age and things like that, but generally a rough answer is on average 4 hours. Now, remember back to the studies we referenced, 4 hours is not sufficient to feel rested, to perform cognitively well, et cetera, but I would say at very least 4 hours. And I say that because there is some data to suggest an increased mortality rate in patients getting less than 4 hours of sleep, independent of anything else. Go to sleep, but wake up totally aware with mind in a whirl, zero chance of going back to sleep. So that falls into all the things I talked about in terms of ways to distract, mental distraction technique. I talked about worry time and writing down and making lists before bed. And not a bad idea is to get up and do those things if you have that running through your mind. But that's really where the cognitive behavioral aspect really thrives for that kind of insomnia. Taking Sonata for 12 plus years on an as needed basis, once or twice a week, is that a problem? So it's probably not terrible. As I said, the subgroup analyses in that data, the gender and time and things like that, we don't have that data yet. I would say that what you've described, once or twice a week Sonata, which is in that class of sleeping pills, is probably not the end of the world. My practice has been just to try to take as many people off of these medicines as you can. If someone needs a medication, then try something different. There are enough other classes of sleeping medications out there these days that often you can avoid it. So it's better than taking it every day, but if you can be off of it completely in favor of something else, then all the better. Do people really sleepwalk? Absolutely. So people can do all kinds of crazy things in their sleep. They can walk, they can eat, they can drive cars, they can be intimate with their bed partners. All kinds of complex behaviors can occur during sleep. There's a whole legal defense of the sleep murder defense, which may or may not have some validity. Plenty of people who have, not plenty of people, but people who have successfully gotten off of their crimes using that defense have gone on to later commit similar crimes and be rearrested. There are people who have probably validly done things like that. But yeah, there are very complex behaviors that can happen during sleep. Does nighttime... I think someone's got their audio on, so I hear myself in reverb. So if anyone can mute themselves, that would be excellent. Because otherwise you have to hear me in reverb, and that's not good for anybody. Does nighttime postnasal drip affect mouth breathing or cause sleep apnea? Sure. So the more nasally congested someone is, the more the mouth is going to come open. Generally, adults are not so reliant on nasal airflow that it's going to cause sleep apnea. Children are exceedingly reliant on their nasal airflow. So kids can have sleep apnea just purely as a consequence of nasal obstruction and postnasal drip and allergic rhinitis. In adults, generally, it's more the straw that broke the camel's back. It's an exacerbator or the thing that pushes you over the edge. Have there been any studies on the usefulness of CBD products on sleep? So CBD products, no. I mean, there's plenty of nonsense studies where people tried, one thing and anecdotally said it, and that's can't really trust it. Most of the data on marijuana and marijuana derivatives in sleep was taken from studies done back in the 70s. They are now starting to do research on on that, but there's nothing good yet. The data from the 70s generally showed that there are two effects of marijuana and marijuana derivatives on sleep. It can help you fall asleep with some strains of marijuana, not all, but that effect generally in those patients, tolerance developed within about 6 weeks. It is also a potent REM suppressant. It suppresses dreams. That's why habitual marijuana smokers often, when they stop, experience vivid, crazy dreams. And that's because of REM rebound, the brain making up for lost time in terms of diminished dreaming while taking it. 20 milligrams of amitriptyline for many years to help with sleeping. Any concerns? Probably not. Amitriptyline is not in that class of sleeping meds, so that's generally would be a reasonable option. No objection there. Where can you get an oral appliance? So those are made by sleep dentists, and there are many of them around. You can go to the sleep dentistry website, NJDSM, I believe it is. Don't hold me to that. You can look up New Jersey, it's AA, American Academy DSM, AADSM.org. You can just Google AADSM.org. Or American Academy of Dental Sleep Medicine, and you can look up local dentists who make these things. You can get non-custom ones online, the internet, drugstores, things like that. Don't use them. They don't work well. They're big, they're bulky. They just don't do very much. They might help mildly with snoring. That's about it. So generally you want to see a sleep dentist. If you have a dentist, you could say, hey, do you make these? You don't want to do, if they say, oh, I can give it a shot, you probably don't want them to be the one doing it. But there are plenty of people in the area. Happy to help. So people have mentioned, I'm responding to the direct messages as well as the global ones. So without any kind of identifiers for the people, if someone has been taking Ambien for 10 plus years, generally the practice is to try to get off of it in favor of something else. If someone needs to be on it, if there's nothing else that works and it's a quality of life decision, then I'm a big fan of, people are adults who get to make their own decisions. And if that decision is to, accept that there is a risk of maintaining on these medications, okay. But it's, if at all possible, at least something else should be tried. Have any new surgical methods been developed? 7 years old, never had my tonsils removed. So generally, in most people, the tonsils shrink or go away on their own by pre-puberty ages. Some people, they don't. So if someone has giant honking tonsils and everything else is wide open, then taking them out might be a reasonable option. I never sugarcoat airway surgery. Tonsil surgery, most surgeries for sleep apnea in the back of the airway are horrendously painful for about a week or two afterwards. Worst sore throat you have ever had in your life. Now, if everything else is wide open and all they have is big giant tonsils, and taking them out would obviate the need to be on CPAP or things like that, then hey, if you can, get through it and pursue it. But generally the surgical options are there. They're just the less invasive surgical options don't work all that well. Like, for instance, the most common historical one, it involves removing the soft palate and parts of the uvula. That's not that big of a surgery, but it only reduces apnea severity by about 10 to 30%. That's not even talking cure rate, that's just reduction. The Inspire, that implanted nerve simulator, is a newer surgical method. There is a particularly effective surgical method involving making cuts in the bone of the jaw and actually advancing the jaw surgically. Works great, but it's a very big surgery with 5-week recovery period. So that just highlights the fact that the more effective the option, the bigger the surgery, and vice versa. Can we talk about sleep studies? So there are two kinds of sleep studies. There are home sleep tests and in-lab sleep tests. Home tests only look for sleep apnea. So that's their biggest limitation, is they're useless for anything that is not sleep apnea. But for someone who's pausing, gasping, snorting, they've got a neck out to here, you know they have apnea, we know they have apnea, everyone knows they have apnea, you just need to prove it so the insurance company will approve treatment. Home testing is very viable. For people who have neurological conditions, lung disease, concerns for other conditions besides sleep apnea, home testing is not useful. In-lab testing is a bit more accurate. However, specifically, home testing, its biggest limitation is it can underestimate how severe apnea is. So if it shows someone has apnea, they have it. It's just a question of, is it underestimating? Let's see. By not falling asleep at night and probably sleeping 2 to 3 hours and can't sleep during the day, would you suggest a sleep apnea test? I wouldn't jump to it. So unless the person had had anatomy which was highly consistent with sleep apnea, or they were snoring during the limited sleep they got, generally for someone who is more seeming to be pure initiation insomnia, difficulty falling asleep, sleep testing would not be my first inkling. Unless there was something else pointing to it. It'd be address the insomnia directly and go from there. Let's see. Does CPAP help to eliminate very dry mouth sleep? Sometimes. So dry mouth during sleep is an indicator of mouth breathing. Now, often when that mouth breathing is a compensatory mechanism to try and get as much air down as possible, often, so by reducing the need by things like CPAP, often the mouth breathing goes away, but sometimes it doesn't. And so it is certainly possible for people to mouth breathe despite CPAP. There are things that you can do to help that. For instance, there are chin straps, which are essentially they're not, but they amount to a rubber band that goes around the jaw here to keep the mouth shut. They're cloth straps. There's something called Somnofix, Somnofix, I think, which is essentially tape that goes over your lips. It's porous, so you can breathe through it, but essentially keeps your lips together. And actually, I've tried it myself. It's surprisingly comfortable for taping your mouth shut. Let's see. Hold on here. I think I got lost in the questions. 1 second. Okay, here we go. How best to sleep on a plane? Seats not designed for sleeping. So it's tough, really. You want to for seats that are not designed for sleeping, there's really not very much you can do. I mean, the things that generally cause people the most trouble would be neck positioning, your neck like this, your neck like this. That's not going to be particularly comfortable for hours on end, and sometimes that can leave the airway crimped and worsen snoring and things like that. And thank you for your thanks. Happy to help. So besides doing things that are supportive from a neck standpoint, so nice, good supportive neck pillows and things like that, and springing for the additional leg room and such, another option would be to take something to help you sleep. Benadryl might be an option. The thing about Benadryl is, just like melatonin, it affects everybody differently. There are some people who are profoundly affected by it. Some people have what's called a paradoxical reaction to Benadryl, where instead of putting them to sleep, it makes them wide awake. So, you also don't want to be so sedated that you're non-functional. So, if I was going to take Benadryl for sleep, I might take it at home on a Saturday when I didn't have to do it or have anything to do, just to see how it would affect me, make sure I can, get myself where I need to be and, interact with the flight attendants and such. But something gentle like that to help you sleep wouldn't necessarily be the worst thing in the world, as long as you've found that you are functional and well tolerated with it. All right. Very good. Well, thank you for being an excellent audience, and have a great day.
Thank you. And I just ask everybody before you get off the Zoom, if you could do the evaluation. It's in the chat box. It's under the Survey Monkey. And thank you very much.
Absolutely. Have a nice day.
Thank you, Dr.
You too.
Dupree.
Thank you. Happy to do it.
Thank you.
You.
Man got hurt that day.